Okay. So our next speaker is to continue our theme on the clinical aspects of Barth syndrome. Our next speaker is Dr. Todd Cade from Washington University in St. Louis, and he's taken something that should have been done years ago approach to Barth syndrome, is really looking at the functional aspects of Barth syndrome in the Barth patients. What are they capable of doing? What are the technicalities of their biochemistry? In what ways are their mitochondria not working on a whole body system? So he has a very sophisticated approach to looking at exercise physiology and the effects of the Barth syndrome defect on that exercise, and he will tell us all about it.
Okay. Am I on? Okay, great. Okay, so as you see from the title, I'm going to be trying to marry some of the studies that we're doing in exercise and metabolism, and so hopefully it'll make it a little more relevant. But I want to first thank the organizing committee for asking me to give this talk. So I'm really excited to share with you and get maybe some feedback on some future directions of what we're doing as far as exercise studies and substrate metabolism studies at a whole bottle and myocardial level in Barth syndrome. So I don't need to go through too much background, but the tafazin mutations in Barth result in the abnormal cardiolipin, and the main tissues that are affected are skeletal muscle and heart, because they have the most cardiolipin levels, the highest levels of cardiolipin in there, and so they're most affected. So that's what we're really interested in, these two tissues. So the reason how we got started on looking at some of these abnormalities in metabolism and exercise are some of the clinical complaints of the boys, mainly excessive fatigue, physical activity intolerance, things like that. And then the clinical phenotype is just very variable in these patients, as far as some complaints of very high levels of fatigue, and some are able to actually participate in sports. It was interesting. I was talking to the boys yesterday, and some are actually participating in organized sports, and some have trouble even walking a city block. So it's a pretty variable clinical presentation. Also, as you all heard this morning, Dr. Kelly talked about the different amino acid abnormalities, which we're going to talk about a little bit in this, and again, clinically variable. And so we're hopefully going to marry metabolism and exercise, using exercise as not only a stimulus to look at some of these abnormalities, but also look at it as a training module to actually improve some of these modules. Okay, so I know that 2 years ago, a lot of you have heard some of these data that I'm going to present, but I think it's important that I present it. It puts everything else in context on where we're going, where we've been. So this is this study that we did 2 years ago at the 2010 or 2008 conference and the 2010 conference, looking at doing exercise testing and echocardiography in these boys, is really done with kind of spearheaded initially by Carolyn Spencer and Barry Byrne, both which are not here. Barry, if you don't know, he's on Kilimanjaro right now. Hiking up there, and Carolyn just went through a major move, so they weren't able to come. So our initial study looking at exercise intolerance in these Barth boys was really to objectify these clinical complaints of exercise intolerance and fatigue, and then to determine if this exercise intolerance was mediated by decreased heart function or decreased ability of the skeletal muscle to extract and utilize oxygen for energy, or was it a combination of both? So we did actually started this in 2006, but really kind of perfected the methodology in 2008 when we were in Clearwater. So what we did is we did exercise testing and echocardiography at rest and at peak exercise in 15 boys. 15 boys with Barth and 9 controls. And the controls were obtained from a convenience sample of friends and siblings here. So everything was done at the conference. And what we did is we did a graded exercise test with continuous metabolic. So we measured peak VO2, EKG, and we also did near-infrared spectroscopy of the lateral quadriceps. Basically, this is a methodology that looks at oxygen saturation of the muscle. So it's an indirect measurement of the muscle's ability to extract and utilize oxygen for energy. It's basically the aerobic component of energy metabolism in the muscle. As I stated before, they did echocardiography, performed at baseline and peak exercise, kind of looking at the cardiac reserve. How is the heart able to respond to exercise as far as delivering the blood to the exercising muscles? So I don't know if Andrew was in here before, but this is actually done here at home at WashU. But basically, this is what they did. They had this complex monitoring system of VO2. Hooked up to the EKG, riding exercise ergometer to peak exercise, and then we did an echo pre and post. So I'm sorry, this is probably not very able to see, can't see very well, but basically we did 13 controls, 17, or this is the age, I'm sorry, 13 years old for, and 17-year-old for Barth. So Barth was a little bit older. Again, this was a convenient sample. Matched as well as we could, a little bit lower weight as we know clinically. That's how the Barth boys present. About half of them were on beta blockers, and most of them were also on, or some percentage of them were on ACE inhibitors as well. And some were on various levels of coenzyme Q or GCSF or carnitine, some things that has been shown really not to be that effective. So basically what we found is this is VO2 here on the y-axis, and this is work rate. So this is during the peak exercise test. So every minute the bike basically got harder and harder to pedal. So this is actually the intensity or how hard it was to pedal. And as you can see, the Barthers in the open circles, the controls are in the solid circles. As you can see, this is peak exercise was significantly lower in the Barth boys. So basically, the Barth boys pooped out at about between 60 and 80 watts, where the controls are able to go anywhere from 180 to 220 watts. So significantly impaired exercise tolerance in that aspect. And also looking at peak VO2, oxygen consumption, or aerobic capacity, looked at a whole body level, was significantly impaired in the Barth boys. Okay, so this wasn't overly surprising. So when we looked at heart rate response to the work rate, as you see that the heart rate was almost overcompensated, so rose at a steeper slope in the Barth boys than in the controls, indicating if there's, and this is pretty typical in mitochondrial myopathies, when the skeletal muscle is not able to extract and utilize oxygen, sometimes the heart rate will increase to increase the blood flow to the muscle to try to almost overcompensate for this defect at the skeletal muscle level. And that's what it looks like here in the Barth boys. So this is cardiac reserve. So basically this is ejection fraction. I'm sure everyone here is familiar measuring ejection fraction, or basically how it's a measure of contractility of the heart. So this is pre-exercise and post. So basically at post-exercise we laid them down and measured ejection fraction. So looking at and normally this should increase with exercise. So you're looking at the controls, and this actually did. So ejection fraction was normal right around 60%, increases to about 75 to 80%, and that's pretty typical for someone who is healthy. But if you look at here, this is these are both Barth groups. Those are on a beta blocker, and those that weren't on a beta blocker. And as you see, the difference between pre and post, their ejection fraction really remained unchanged from rest to exercise, indicating a defect of the heart. The heart was not able to upregulate its ejection fraction or contractility with exercise. Okay, so that was blunted. And the reason we broke them up between beta blockers and non-beta blockers is because beta blockers actually have an effect as far as decreasing contractility of the heart. So the reviewers certainly wanted to see, was it this effect of a beta blocker, or was it actually the effect of the Barth syndrome? And as you see, both groups did not improve, so there is an effect, certainly, of Barth syndrome. So when we looked at skeletal muscle oxygen extraction measured by NIRS, this is oxyhemoglobin and deoxyhemoglobin. So looking at basically the saturation of the hemoglobin with and without oxygen. And with exercise, basically the saturated oxygen hemoglobin should decrease with exercise intensity, as you see with the controls that this did happen. But paradoxically, in those with Barth, it actually rose. So really the unloading, so skeletal muscle oxygen extraction was impaired. Same here with deoxyhemoglobin. With exercise, you see normally with the controls, this should actually increase with exercise, and it does with the controls, but it actually really doesn't change with the Barth. So this was really an indicator that skeletal muscle oxygen extraction was impaired in the boys with Barth. So total hemoglobin, which is basically an indirect measure of total blood volume, or a real crude measure of blood flow, and it should increase actually with work rate, and you see that with the controls and with the Barth as well. So really, oxygen or blood flow delivery does not seem to be impaired in the Barth boys. And then looking at respiratory exchange ratio, basically what this is the ratio of VCO2 over VO2, and just real grossly, a respiratory exchange ratio of 1 indicates basically you're oxidizing pure carbohydrate, and a RER of 0.7 is an indicator that you're basically burning pure fat. So during exercise, this should, as you need more immediate energy, this should increase to over 1. As you see, that's what happens with the controls. And once you hit about 1.1, it's kind of an indicator of, yes, you've hit peak exercise capacity. Your muscles start to burn. You start to have very high ventilation rates. But as you see with the Barth boys, it is significantly higher. This is a very high level of an RER. So basically, they are burning or oxidizing glucose, and actually their ventilation's high. So they're basically trying to get rid of a lot of CO2. So just basically this indicates that they are using more glycolysis for energy during exercise than the controls. Okay, so what do we learn from this study? That the Barth boys had severe exercise intolerance. The exercise intolerance is mediated by both cardiac and skeletal muscle impairments. It seemed to be compensated, again, this is just grossly at the whole body level, by elevated glucose and lactate metabolism, again, so indicating that aerobic metabolism was impaired. And this seems to be consistent, kind of what we know about Barth. So this led to the question, can these boys with Barth effectively and safely endurance train? Can they undergo an exercise training program to improve their exercise tolerance? I mean, we know there's thousands and thousands of studies that exercise training in healthy and many other diseases, most diseases, that exercise training is effective. Even in non-Barth heart failure, it's effective in increasing exercise tolerance. Some studies, it's actually effective in increasing heart function, quality of life, things like that. And if exercise training was effective, would the improvements come from increased cardiac function, skeletal muscle function, or both? Or, as Dr. Kelly actually a couple years ago suggested, would endurance exercise training just increase the number of impaired mitochondria? So we know with endurance exercise training, the skeletal muscle mitochondria number and function actually increase, and that helps mediate some of these improvements in exercise tolerance. But in the Barth boys, would this just increase the number of defective mitochondria and not see much of a difference? So this is what we did. So this was funded by the Barth Syndrome Foundation, and so to look at the effect of an endurance exercise training program. So we'll talk about how that looked. But basically, right now, we've completed 3 participants, and 1 is ongoing. So we looked at basically adolescents and adults, really probably the easiest group to look at as far as the IRB is concerned. And so what we did is the first participant was 22 years old. He's done. Participant number 2 is 21. He's done. And 28-year-old, he's done as well. And participant number 4, we had some bumps in the road, but we had to move, and we're actually awaiting IRB approval of the training site. So hopefully that'll get started next month. So what we did is we used the pre-exercise testing values, the peak exercise test at the 2010 conference last year in Orlando. So basically what we did is we did pre- and post-testing, same deal. We looked at exercise tolerance through peak VO2. We looked at using NIRS. We looked at muscle oxygen extraction. Then we also did the exact same thing pre- and post resting, exercise, heart function. And we did an aerobic training program on a cycle ergometer. So we use endurance exercise because there's so much evidence that endurance training is beneficial, is increasing exercise tolerance. So the goal was to increase exercise 3 times a week for 12 weeks, so a 3-month exercise training program. The goal was to exercise at 45 minutes continuously at a moderate intensity, Borg scale, at study completion. So we used the Borg scale for moderate effort because most of these guys are on beta blockers, and heart rate is not a great indicator of exercise intensity. So they exercised 3 times a week for 12 weeks. It was performed at a PT or a cardiac rehab site in the other participants' home. Obviously, having them come to St. Louis 3 times a week for 12 weeks was a little difficult for them. So, and then we also assessed quality of life by the Minnesota Living with Heart Failure questionnaire. And then post-testing was done at WashU. So this exercise training summary here, this is basically the guys that did complete. It gives you an idea on how long they trained and what percentage of heart rate. So basically, as you see here, this is participant 1, 2, and 3. A month 1, 2, and 3, and this is the average of the exercise data here for everyone. So we looked at exercise time. So participant number 1 did great. So again, you have to look at this. This is with breaks. So a lot of these guys would exercise for maybe 10 minutes and take a break for like 2 or 3 minutes and then start exercising again. So this is total exercise time. So he was exercising almost an hour. So he hit his goal almost right away as far as total exercise time. And this doesn't really indicate on how long they can go without. But most of these guys said that they were able to exercise, except for participant number 3, at the end of the study about 45 minutes at a moderate intensity without stopping. Exercise heart rate, as you look here, it's about 50% of their predicted peak, heart rate max. So we're looking at the moderate intensity level here. So everyone was able to achieve that. This is just blood pressure, so it didn't adversely affect blood pressure. Average RPE, as you see here, and it's very similar. So this is about a moderate intensity. They're perceiving a moderate effort. And then here's your average watts here. And as you see, participant number 1 was able to do significantly more than the other two. So basically, the bottom line for this slide is we're able to achieve our goal of moderate intensity exercise. So really not much of a change. Actually, they gained a little bit of weight, which was actually surprising. No real issues as far as neutrophil count. Again, this was measured from conference to post-testing at WashU. So sometimes there's a couple-month gap in between starting testing and then starting the exercise program. So it wasn't done perfectly. There is a little bit of a decrease in neutrophil count, but again, sometimes there's a gap. So it's hard to tell if it actually had an adverse effect on neutrophil count. Hemoglobin didn't change, hematocrit didn't change. BNP, again, it was pretty variable, but overall really didn't increase. So it's not really impairing heart function, it seems. And then prealbumin decreased just a tiny bit. So this is just a post-exercise cardiorespiratory. So peak heart rate, they're able to reach the same peak heart rate. So here and percentage-wise as far as pre-post exercise, and then peak RER did not change as far as that goes. So the exercise tests were comparable pre and post. So basically, as you see here, this is participant number 1 in the black, participant number 2 in the open circles, and then the triangle circles is participant number 3. So we're looking at VO2 per kilogram body mass, and then absolutely. And looking at here, very 2 guys actually improved in their peak VO2. Here expressed per kilogram body weight or absolutely, and 1 basically didn't change at all. Okay, so 2 of the guys improved and 1 didn't. This is exercise time, so this is basically just total time during exercise tests on the treadmill. Again, 2 improved, 1 did not. So when we looked at peak muscle oxygen extraction, this is deoxyhemoglobin, so this actually should increase. Very variable. 1 actually went down, 1 increased, and 1 didn't change at all. But interesting, looking at quality of life score. So if you know anything about the Minnesota quality of life, a lower score is actually a better score. So 2 of the participants actually significantly improved in their perception of their quality of life, and 1 actually didn't improve. And this is actually the one who didn't change in his exercise tolerance. So what do we basically conclude? That endurance exercise was well tolerated and safe. So these 3 participants all had ICDs, so they had a higher risk of arrhythmias, and we had no issues as far as that goes, as far as any kind of adverse events with that. So it's well tolerated. Everyone said it was okay to do, and obviously it wasn't exactly easy, but they were able to tolerate it well. It actually increased exercise tolerance about 10%, really. So which is, if you look at the literature, which is actually blunted. Most people get at least a 15 up to 25 or 30% increase in peak VO2 following this similar regimen. So it seems like in the Barth boys that this is actually a mildly blunted. Muscle oxygen extraction improved in 1, but really overall didn't really change very much. As far as the heart rate data, I'm still waiting for some of the data from Carolyn, but really looking at the data, it really didn't improve pre-post ejection fractions. So it didn't seem to really improve heart function very much as well. But good news, it didn't decrease it. Again, interestingly, quality of life significantly increased following exercise training, so these guys felt better, even though their exercise tolerance didn't increase that much, but they felt better. I think it could be a confidence thing, able to get out and feel they actually do exercise without any issues. So clinically, I think it's important because actually in the Minnesota Quality of Life questionnaire, I looked at it and just breaking it down. Again, this 3 subjects, but most of the increases seem to be an improvement in the ability to do recreation and yard work, but really no change in ability to walk and climb stairs. So the questions that remain from this study is, would a longer training program, say a 6-month training program or a year, would that further improve exercise tolerance? Or would resistance training be more effective? So basically, with the question that Dr. Kelly raised a couple years ago, does endurance exercise training just increase the number of bad mitochondria, and is that why we don't see much of an effect? And would targeting muscle fiber types that have less of the mitochondria, like type 2 muscle fibers, would that be more of an effective treatment as far as to improve exercise tolerance, quality of life? So that's what we're going to do. So we just received a Barth syndrome grant to actually look at resistance exercise training. So we're looking at, basically the regimen would be very similar as far as time and frequency. And the reason we thought this might be relevant that other populations, including non-Barth heart failure, it seemed to, as I stated before, seemed to receive a greater benefit from endurance exercise training than the Barth guys. And the blunted effect may be just due to inherited pathogenesis. So as you saw from the RER data, that the Barth guys seem to be more reliant on glycolytic metabolism during exercise. And endurance exercise really primarily targets the type 1 or more affected muscle fibers than resistance exercise training. And there's good data in non-Barth heart failure that actually those who cannot undergo endurance training, those who do the resistance training or strength training, actually have a pretty good benefit from this type of exercise program. So what we're going to do is we're actually going to start next month, and we're funded for 3 adolescents, young men, so basically same age. We're going to look at the safety of 12 weeks of supervised resistance exercise training, so same paradigm, 3 times a week, exercising at a physical therapy or cardiac rehab clinic near their home. So we're going to look at very similar thing. We're going to look at exercise tolerance. We're going to look at heart function, skeletal muscle strength and mass, whole body protein synthesis. So we're going to actually look using tracers, which I'll talk a little bit more about in the next few slides. When you exercise train with resistance training, you should actually increase your whole body protein synthesis rate. That helps with the muscle hypertrophy that you get. And then quality of life. And then we decided as an exploratory aim to try to put some flux levels, as Michael earlier asked about, since we have these guys captive at WashU, to look at arginine metabolism and its response to resistance exercise training. So what we're going to do is we're going to look at a heart and skeletal muscle creatine kinase levels. We're going to do the exercise tolerance, again, with the exercise testing, heart function, muscle strength. We're going to look at 1 rep max testing and isokinetic dynamometry using the same quality of life questionnaire. And we're going to look at whole body protein metabolism using the things that we've been doing, the 113C leucine. So basically we infuse 113 stable isotope leucine tracer, and by taking blood samples, we can tell the basically whole body protein breakdown and whole body protein synthetic rate and at baseline and in response to resistance training. We're going to look at arginine metabolism and looking at basically the clearance rates and the incorporation rates of synthetic rates of arginine using an arginine and a citrulline tracer and mass spectrometry. And again, so we figured since we're already going to have these guys captive and we're going to be infusing leucine, there's no other real trouble, just a little added expense to infuse some arginine and citrulline tracers to look at basically arginine metabolism, arginine flux, and see if we can see if there's any abnormalities to put some data behind some of the hypothesis and some of the serum levels that we see. And then we're going to begin doing this next month. Okay, so as I transition here in the next 15 minutes from the exercise studies to the substrate metabolism studies. So when I first came here in 2006, I worked with the initial exercise study looking at this, and we knew that there was a severe exercise intolerance. So I thought that potentially, because of aerobic metabolism was impaired, that fatty acid metabolism would be impaired and consistent with this low exercise capacity that we see in the Barth guys. In addition to clinically, as you look at these guys, they have low skeletal muscle mass. That would also be suggestive of potential amino acid impairments, and also from Dr. Kelly's data too, that whole body protein and amino acid metabolism would be impaired. So the methodology that I was using in our populations with HIV, the stable isotope tracer methodology, which I just mentioned, would be an ideal way to look at potentially some of these abnormalities and how they contribute to the disease. So again, what was known, so that we knew that there was cardiolipin and amino acid abnormalities. I wanted to look at whole body amino acid and fatty acid metabolism in this. And this is my initial grant that I received from the Barth Syndrome Foundation to look at whole body fatty acid and amino acid and also glucose metabolism as well. So my hypothesis was, again, fueled by Dr. Kelly, is that there potentially could be alternate fuel use in the heart and skeletal muscle, because this alternate fuel use, if you're not able to use fatty acids properly, they're going to use something else to provide ATP. And in this case, potentially could be glucose and also obviously amino acids. So what we did is we did this also because a number other non-Barth heart failure has shown that the heart myocardial fatty acid uptake and oxidation was lower, and then they seemed like they compensated with glucose metabolism and, again, other non-Barth heart failures. And then whole body abnormalities in amino acid metabolism were also have been reported in other, again, non-Barth heart failure. So providing a lot of evidence that potentially this be going on in Barth. And there's a cardiac cachexia hypothesis. Basically, if you're not able to use fatty acids, the heart and skeletal muscle properly, you're going to steal maybe potentially amino acids. And chronically, if you steal amino acids from the largest source of amino acids, which is basically skeletal muscle and heart, potentially that can impair function over the long haul. And that was the working hypothesis. So we didn't know whether nutrient metabolism abnormalities mediate or contribute to skeletal muscle and cardiomyopathy in Barth. So the overall objective of the study was to collect preliminary data on the following hypothesis. So impaired whole body fatty acid oxidation leads to abnormal cardiolipid accumulation and decreased left ventricular function. So just to back up a little bit, this lipotoxicity hypothesis has been very popular in other diseases such as diabetes and heart failure, where if the heart or skeletal muscle is not able to use lipid properly, not able to oxidize it, even though uptake is normal, that these tissues will overall accumulate fat in the heart and in the muscle, and that seems to lead to insulin resistance and also decreased function in other hypotheses. So that's what we wanted to look at as well. And then secondarily, elevated whole body protein degradation, so basically whole body protein breakdown, leads to skeletal muscle wasting and overall decreased left ventricular function in Barth. So what we did is looked at 5 boys and young men with Barth, and then 5 age-matched controls, and tried to match them per body weight as best we can. Again, 15 to 25 years. We just looked at guys in the U.S. and Canada, just logistically the easiest to look at and willing to travel to St. Louis. So all the participants underwent a DEXA for body composition, able to look at lean body, fat-free mass, and also fat mass. We did an acetate infusion correction factor, which I don't need to explain very much, but that just basically corrects for fatty acid oxidation. We did a resting echocardiogram with strain analysis. We actually looked at the fat content in the heart, so looked at cardiac lipid content in the heart to assess this lipotoxicity theory. And then we did a one-stage hyperinsulinemic clamp infusing a fatty acid tracer, a leucine tracer, and a glucose tracer. And we took breast samples, which I'll explain a little bit later, to look at fatty acid oxidation. But for those who are not familiar with this is a pretty standard procedure in metabolic studies, so where we look at their metabolism during fasting, about 2 hours of fasting, and then we infuse a decently high level of insulin. And by giving them glucose back, we can look at a pseudo-fed state looking at metabolism. And this is pretty well described in other methodologies. So basically what we did is we infused a deuterated glucose and a deuterated leucine and a 13C palmitate, and then we looked at them for basically 2 hours in a basal state. So they're all fasting that morning. They came in over after an overnight fast. So we were able to look at substrate metabolism during the fasting or basal stage, and then we infused 40 microunits per meter squared per minute. So I would say it's a moderate dose of insulin. And then we also infuse variable dextrose levels. As you know, if we give them insulin, we need to give them some sugar too, or I'd be out of business very quickly. So then we were able to look at substrate metabolism, and then we took fatty acid kinetics at baseline, at the end of the 2 hour period, and then at the end of the 5 hour period. So this is a general setup here. So as you can see, the tracers are up here being infused. This crazy thing here is basically what we measure during exercise, but it's for resting, is measuring CO2 production, oxygen consumption. So it's a metabolic cart. And we use this mainly to get expired VCO2 needed for fatty acid oxidation rates. So when we infuse the fatty acid, the 13C labeled fatty acid, this is a much more simplified version of the Krebs cycle, but what happens is when the carbon's labeled on the fatty acid as it goes through the Krebs cycle, it spins off CO2 down here and CO2, so they're basically the label that's on the fatty acid comes off from the label that's on the CO2, And by collecting expired breath samples here and putting it on a mass spectrometer, we can determine fatty acid oxidation rates in conjunction with plasma levels of 13C palmitate. So this has just been published, but so I'm going to only have a few minutes left. But briefly, the controls in Barth were matched pretty well. Looking at BMI was not any different. Weight was significantly lower. That's pretty much been reported clinically. The white blood cell count and neutrophil cell count was lower as well. Again, it's been reported a lot in the literature. We just heard a lot about that. So looking at body composition, fat-free mass was significantly decreased in the Barth. So this is basically putting a quantification on what we see clinically as using DEXA. Whole body fat-free mass is significantly decreased. It also looks like fat mass is trending to be elevated. Again, this is only 5 participants, but it seems like they have a little bit more fat mass too. Again, clinically, this is kind of what we see. No difference in serum glucose. Fasting insulin was no different. It was a little bit elevated, but that was really because of one participant. HDL levels were similar. LDLs were as well. Total cholesterol, although usually it's reported as lower, was no difference. Triglycerides tended to be a little bit lower, but as been reported by Dr. Kelly, a whole free fatty acid level was almost 3 times the amount in the Barth guys than in the controls. And then lactate was a little bit elevated. Again, that was really variable and was really driven by one participant. So just briefly looking at heart function, what we did is we measured using tissue Doppler, heart function, heart contractility. That was a little bit lower in Barth, and using diastolic function was also a little bit lower. Again, things that have been reported. So when we looked at the kinetics of glucose metabolism, so the reviewers wanted us to present this both as a whole body, so not normalized to fat-free mass or normalized to fat-free mass. And typically in metabolic research, it's measured per unit of fat-free mass because fat-free mass, again, was different in the Barth guys. So as you see here on the y or the x-axis here, you have this is basal and hyperinsulinemic. So this is glucose metabolism here. Basal and hyperinsulinemic, and as you see, I'm going to focus more on the fat-free mass. As you can see, looking at glucose RD is basically when you give insulin, how much glucose the muscle is able to put away. So it's a kind of a measure of insulin sensitivity in a way. And it seems like when you give insulin, the Barth group seems to have a greater capacity to put away glucose during insulin. But when you normalize it per insulin unit, there's really no difference. So they're not really more insulin sensitive in a way, but it seems like they're able to put a little bit more away, a little more glucose. So when we looked at fatty acid metabolism kinetics, so this is palmitate RA, which is a measure of whole body lipolytic rate, so fat breakdown rate. And when looking at it again per unit of fat mass, it seems like it's actually a little bit lower in Barth, so during the basal level. So, and that may be driven, we'll talk a little bit about that, but that may be driven because they just have high free fatty acid serum levels. But it doesn't seem like the high free fatty acid serum level is driven by an increased whole body lipolytic rate. And then when we looked at amino acid kinetics, I'm sorry, did I miss? Yeah. Amino acid kinetics. I'm actually going to, I don't think I have a slide on this, so I just want to make sure I meant. So when we looked at whole body free fatty acid oxidation, we didn't see any difference at all. So at rest, free fatty acid oxidation, which has been basically hypothesized by Dr. Kelly, was no different. Okay, so they're able to, at rest, able to oxidize the same amount as healthy controls, which was contrary to our hypothesis. So then when we looked at, we infused deuterated leucine, and we looked at amino acid metabolism kinetics. Again, we'll focus per fat-free mass. When we look at basal level, fasting levels, it seems like the Barth guys actually had an elevated whole body protein breakdown rate. So they broke down more protein at the basal level, but it seemed to be suppressed to a similar amount when you gave insulin. So, and then I'm not going to go through this again, but basically we found the same thing as Richard does as far as decreased arginine, elevated proline levels. Again, this was a little bit different than his data because it was a little longer of a fast. This was after an overnight fast, so it wasn't really comparable to his methodology. And then when we looked at the relationship between the increased baseline whole body protein breakdown rate and strain, so a measure of contractility. There's tended to be a relationship between increased whole body protein breakdown rate and lower strain. So it's potentially providing some evidence of this amino acid abnormalities in metabolism and decreased heart function. So in the last 5 minutes, let me just roll through this. Basically, we found that glucose disposal during hyperinsulinemia increased in the Barth guys. However, insulin sensitivity overall really it does not seem to be increased when we normalize it to plasma insulin levels. The elevated whole body serum free fatty acid level that we see in the Barth boys is normally suppressed with hyperinsulinemia. And then whole body lipolytic rate is lower, but really does not appear to be the cause of the increased free fatty acid, increased serum free fatty acid levels. And neither does free fatty acid oxidation at rest either. So it's not the inability at rest. As I stated, so fatty oxidation was similar at baseline, but the question is, do you need mild exercise to stimulate? So when you start walking around or exercise, you actually increase your free fatty acid oxidation rate. So is this a stimulus that we need to use to actually see a defect in these boys? Whole body protein breakdown was increased during baseline and hyperinsulinemia. As we stated before, specific amino acids were different. When we measured, I didn't state this, but when we looked at cardiac lipid, no differences between the two groups. So they're not accumulating increased cardiac lipid in the Barth boys. And then this whole body protein breakdown rate at rest seems to be associated with lower systolic function. Again, there's a tendency for that, but again, low numbers. And then so this provides some evidence for this cardiac cachexia hypothesis that we talked about. So where are we going with this in the last 2 minutes here? Fortunately, we just received an R1 to really expand these studies. So we just received funding a couple months ago, and the overall hypothesis of this is that heart fatty acid metabolism is severely impaired during exercise and activity. So we didn't see this during rest, which facilitates increased cardioskeletal protein catabolism, which we talked about, amino acid supplementation for energy, and enhanced glucose metabolism in order to supply the energy need for muscle function. And because that amino acids and glucose provide an inherently lower amount of energy, an energy deficit will occur. And we think that these impaired energetics during exercise, because we know that during rest that's not the case, mediates and exacerbates the exercise intolerance, fatigue, muscle wasting, and heart failure in Barth. So what are we doing? So what we're doing is we're looking at 15 adults with Barth and 15 kids with Barth, and then we're looking at characterizing skeletal muscle fatty acid oxidation, amino acid proteolytic and oxidation rate, glucose disposal at rest, and also during low-intensity exercise. So we're using exercise to stimulate the increased fatty acid oxidation rate, and hopefully that'll also see the deficits in the amino acids breakdown as well. During basically a half an hour, very low intensity, kind of simulating walking. And then that recovery, and then we're going to characterize myocardial fatty acid, amino acid, and glucose metabolism in the adults by using radioisotopes and PET imaging. So there's a technique that we're also able to look at specifically the heart, how the heart utilizes fatty acids, amino acids, and glucose by using radioisotopes and doing PET imaging of the heart. So we're able to really, rather than just looking at a whole body level, actually looking at how the heart is able to metabolize. And obviously with some of the radio exposure of radiation, the adults are really the only ones we're going to look at in this. And then using stable and radioisotopes, mass spectrometry, and PET imaging, hopefully we're able to quantify this. Then we're also looking at energetics and function on all the boys. So we're looking at using 31P MRS in the heart and the skeletal muscle using exercise, echocardiography, and exercise testing, trying to put a functional level to all these impairments as well, see if we can see a relationship between metabolism and function. And then we have an exploratory aim, and this is in conjunction with Barry Byrne. We're actually going to get skin biopsies of the boys and the adults and then induce them into, and this is with Megan as well, induce them into myocytes, skeletal muscle myocytes, to look at more chemically and molecularly some of the pathways that may be affected. So hopefully we're able to look at heart, whole body, heart, and molecular levels, impairments in the mitochondrial function metabolism as well. Okay, so there's a lot of people to thank, but certainly we want to thank Carolyn Spencer, which has been obviously integral in the exercise studies, and Melissa, who was coming here, she was very integral and is helping out as well, and Barry, of course. Megan's going to be doing some of the analyses, I think, on the inducible pluripotent stem cells. A lot of different grants at WashU that's really supported a lot of this work. Obviously, special thanks to the foundation for funding a lot of these studies. And then certainly the participants that travel to WashU and are willing to get stuck with needles and sit and watch TV for hours on end. So really appreciate that. So sorry, I think I tried to jam in a lot of things in the last 45 minutes, and thank you for your attention. Okay. Oh, yeah.
Very interesting study. So you show the fatty acid oxidation rate is not changed. Did you ever profile isocarnitines from blood? Because the incomplete fatty acid oxidation generate, isocarnitines. Those are byproduct that causes mitochondria being overloaded and dysfunctional.
Yeah. No, we didn't look at that. And this is a very whole body level. So it's only one fatty acid that they're infusing, and in metabolic research, the palmitate is supposed to be representative of all the fatty acids. So it's a real general level. So we haven't looked at that. So we have the capability to look at that. So we have plenty of mass specs to look at the different levels of the acylcarnitines.
Exactly my question.
We should.
Yes.
Okay. Then we should talk about how we should. Is there a special? We'll talk about it after. How do you keep it prepared as far as looking at it in plasma or whatever, however it should be preserved?
Yeah, that's very simple.
Yeah.
Todd, a great study, actually. I think this is the way to move forward and to really shed light on the underlying problem there. What for me was a surprise, actually, to see was when you did these work rate experiments, that in the controls there's this gradual increase from 0.7 or so to 1 in increased carbohydrate oxidation, whereas in the Barth syndrome patient it speeds off immediately. So there's no flexibility actually in the heart to shift over and accelerate fatty acid oxidation and move basically to glucose oxidation. Do you have any idea why this inflexibility there is actually? Is that the mitochondrial problem which is playing a role there?
Yeah, so yeah, it's a great question. This is why we think that we see normal fatty acid oxidation arrest, and as soon as you stimulate with exercise, that's where we think we're going to see the impairment. And this would be consistent with what Richard was talking about, almost like a log jam in the TCA cycle. Is as long as you don't have this increased pyruvate trying to get into, or acetyl-CoA trying to get into the TCA cycle, that there's a log jam, there's a blockage there that kind of backs it up, and right away they go to glycolysis. So they're not able to have this nice smooth transition to a point. So there will be a point where, during even healthy controls, you get it to an intense exercise where you're going to need to start supplementing more with glycolytic substrate metabolism, but they reach it obviously at a much, much earlier level. So, there's some kind of logjam in the TCA cycle that they're not able to flux through well.
Yeah, so I'd make a couple of points, and I agree that this is the way to find out a lot about the function, especially the myocardial PET, I think, will be very illuminating. I would suggest the hypothesis that the underlying substrate utilization is very different in the boys, that they're adapted to their state. But unfortunately, I think the way you've done some of the studies mixes fast skeletal muscle and slow skeletal muscle results. So separating those out either by NIRS or some other methodology would be very helpful. My guess is that the muscles are actually very different than the controls in terms of whether they're adapted to glucose or adapted to fatty acid as substrates. So I think that complicates the results. And I think the fast increase in glucose utilization with exercise, actually, I think there is a difference at baseline. Probably is indicative of that adaptation. So I think they're great studies, but clearly indicate that there's a lot of differences. And then, of course, you're studying older patients as opposed to younger patients, which may be quite different, and we think they probably are because of their clinical phenotypes. The last point I'd make is that the beta blocker is a huge complicating factor. And are you going to try to control for that in your studies because of its impact on fatty acid oxidation in particular?
Yeah. We haven't talked about it, so obviously there's some ethical issues as far as taking people off their fatty acid, their beta blockers and things like that. Potentially we could do it the day of, so you at least get rid of the acute effect of the beta blocker. As far as the adult versus child question, the R01 is actually going to look at boys 8 to 17, so we're hopefully going to be able to answer some of the questions about the younger guys.
Yeah, I know it would be very difficult, potentially ethically, to remove the beta blocker. On the other hand, I think it's going to complicate the interpretation of the data so much. And the efficacy, I think, is a real issue.
Yeah.
The fact that your boys' heart rates can go up, right?
Right, yes.
Extremely quickly. Are they really beta blocked or not? Some of the things indicate they are, and some of them that they're not.
They do. When you look at the peak percentage heart rate between controls in the Barth, it is lower. But right from that graph, they accelerate pretty quickly, or quicker than the controls.
Any other questions for Dr. Cade?
Another question. I just want to see the results from you. You showed fat mass decrease, a lot of lipids pattern, not change, but only two change. I just want to double check. You can only write down one.
Is this the slide you're talking about?
Yeah, PT down and fatty acid, free fatty acid increase.
Right. It's about 2.5 to 3 times. This is fasting plasma.
Okay, thank you very much.